So, good evening, everyone, and welcome to part two of YEARMED, which is basically the year-end review of the best research work that has happened in the field of endocrinology. Now we are moving to obesity and metabolism, and next week we are going to have a session on diabetes. So today it's an absolute privilege to have with me Dr. Tejal Lathia. Dr. Tejal is, I think she needs no introduction, but I mean, it's a formality, so I'm just doing this. She's a good friend of mine. So Dr. Tejal is a endocrinologist from Mumbai, and she's very passionate about communication in medicine, not just endocrinology, communication in medicine per se. And most of her research work right now is centered around communication. So whether it's a one-on-one communication with patients or whether it's a written communication, she writes beautiful blogs. She's an avid reader. And she also has a keen interest in this field, particularly obesity and metabolism. So she's, very passionate about her clinical science as well. Again, a lot of her patients, talk about her empathy and talk about her, the way she has her approach to people, not just medicine. So I think very perfect person for our session 2. That is the session on obesity and metabolism. So those who had joined us for the first session will be well aware of how we generally do this thing, right? So what we generally do, Dr. Tejal, is that we have this little bit of a presentation where we share the research articles chosen by us, and then we open it up for some polls as well as some questions from us, and we can discuss that in more detail. And there are certain research articles which you kind of club together because simply for the fact that they kind of follow a particular theme. So that's also the thing. And again, for viewers, if you are well aware that you can access all the course material that we are going to have, all the full text of the research articles, the summaries, some additional notes, also some mini applications which you can use. I'm going to show them as well as we go along. So you can access all of this on technocrinology.com. So just go to technocrinology.com, sign up, and you'll have the YEARMED available to you, and then you can sign up for that, again free of charge. And then you can access all the material and this recording as well, what we're going to discuss, as well as the future the next session as well. The previous one, everything is available on the platform. Okay, so let's dive straight in and let's launch a little poll. So let's start with this. What are your views on BMI as an indicator for obesity? So this is a poll, it's not a quiz. So poll is something, where we seek your opinion. And we already have, about 20-30 people who are already joined in on time, which is great. So is it the perfect indicator for obesity, or is it good, but I'm looking for a better indicator, right? So as of now, as we are, running this poll, well, 100% have said that, it's a indicator that needs some bit of improvement, right? So, Dr. Tejal, let's start with this as the starting point, right? What is your broad view on BMI as a good indicator for obesity?
So do you want to talk about this research article, or should I just maybe say?
Yeah, just give your general opinion of the flaws with BMI. What's the problem with BMI?
So overall, BMI is great when you're looking at it at the population level. Yeah, so overall, you can, talk about the health of a population and, how the population is doing. But on an individual level, there are some kind of constraints with BMI. I think the most important is that when you calculate the BMI of a person, you don't know what is the muscle mass and what is the fat mass. So that's extremely important. So like somebody said, Arnold Schwarzenegger would be classified as obese if you use BMI as an indicator of his health. So I think the most important part is it doesn't tell us much about muscle. It also doesn't tell us much about fat and where the fat is located. So we all know about subcutaneous and visceral fat, and visceral fat is something we're interested in because we'll talk more about it maybe later in the session, but it gives us no information about that. BMI also is susceptible to some other flaws, like if there's fluid retention, If somebody has a higher bone mineral density, they have heavier bones. So many of these small things are not taken into account for a BMI. And because of that, I think there's been a lot of research where people are trying to capture more about the fat component of the weight as well as the
Right.
location of this fat to give us a better idea. And obviously, all of this is being done because ultimately we want to predict cardiovascular disease, we want to predict metabolic syndrome, we want to predict mortality, and somehow we want to intervene in our patients at an or in the people around us at an earlier stage so that we could prevent maybe these conditions.
Yeah, so great starting points. And again, audience, if you have any questions, please feel free to write it in the chat, and we'll take up the question as we go along. Some of them will integrate with our current discussion, and some of them will take it in the end as well. So run to the poll again. So 78 and almost 70 to 80% of the audience really wants a better indicator for measurement of obesity. So that's the result of the first poll, which is great because the first two articles that we're going to discuss today are themed on looking at a better indicator for measurement of obesity. So first is a little bit of research article on Body Roundness Index. Now, just to give you a concept, Body Roundness Index is not new. It's been around since the last almost a decade. So it's a geometric tool. First, it was first introduced in 2013. And the idea was to get a slightly better estimate of the visceral body fat. Right now, as Dr. Tejal very rightly said, the body fat, you can have the subcutaneous fat and the ectopic fat. And the ectopic fat, one of the components of ectopic fat is the visceral fat, which is the central adiposity. And that has direct correlation with cardiovascular disease as well as the other metabolic complications. So the idea was to capture this visceral fat. And then this visceral fat, this specific number is not captured easily by body mass index. So that was the idea of introducing the BRI. The BRI it's a slightly complicated calculation. So this is the formula for calculating the BRI. Now, you need two parameters. You need the waist circumference and you need the height. Both of them have to be measured in the same units, preferably in centimeters. This original indicator was given in terms of centimeters. So just two measurements, the waist circumference and the height, and then put it across this formula, and you'll get the body roundness index, right? Now, you get a value which is ranging from 1 to 16, with most individuals between 1 to 10. So that's the value you get. Now, the existing studies have shown that the interpretation is that less than 3 suggests that there is a midsection leanness. If it's around 5, it's a medium index considered to be more or less normal. But if it's more than 6.9, that is more than 7, it generally suggests a wider, rounder body. And that's associated with the increased health risk. So this was based on the original study. Now, there was a study recently published in JAMA, which I think, looked at this more closely. And what they did was something very simple. They looked at the all-cause mortality associated with the body roundness index, which from the, so it was a retrospective study, and they looked at the data, and they looked at the BRI, and they looked at the, all-cause mortality. What they found was that there was a U-shaped association between the body roundness index and all-cause mortality, showing that there was an increased risk at both the extreme high values and extreme low values. Okay, so both these areas you had increased risk of mortality. Remember, we are looking at all-cause mortality. So they looked at data from 1999 to 2018, which showed that overall also they saw that there was increase in the mean BRI, especially amongst. So this is mainly US data. This BRI values have been increasing over a period of time, especially in women, elderly, and Mexican Americans, where the BRI values are. And Mexican Americans, Hispanics like us Indians, are at a little bit of disadvantage. They tend to have more of the central adiposity. And overall, this study concludes that the BRI is a good assessment of visceral adiposity compared to BMI, and it shows it's a good, promising non-invasive screening tool for looking at the overall mortality risk of the patient, right? So the study basically concludes that BRI has a slight advantage in terms of predicting mortality, and should be probably used in future in place of BMI to look at the overall health risk and the mortality risk. Now, again, on the platform, so if you go to technochronology.com, you will find the simple calculator for BRI. So very simple to calculate. So all you have to do is you have to, whatever measurements you're using, you calculate the BRI, and again, it will give you not only give you the value, but also give you the interpretation. So I put the data for myself close to what I probably have. So it's 5 feet 11 inches and 100 centimeters in terms of, the waist circumference. And it comes to around 4.4, which is considered to be okay, right? Again, if you see from the data, more than 6.9, you have increased mortality risk, and less than 3.4 also, there is increased mortality risk. So that again is something which is very interesting, right? So you can calculate this. So we already discussed that, Dr. Tejal, that, BMI is not the perfect indicator, for the facts that you said. What's your view on BRI, right, as a potential marker for obesity?
So, first of all, I also want to say thank you very much, Om, because I felt like I was a resident again, and then I had to read the papers and I had to remember all the facts and everything. So it was also a fun exercise for me to go through this. I'll be very honest. So there are, of course, flaws with BMI, and BRI is definitely a step up from BMI,
right,
because
right.
BRI does take into account, the waist circumference, which gives us some idea of the visceral fat, and therefore will probably be a better correlate with metabolic syndrome and cardiovascular disease. However, somehow this BRI has not really taken off, and the amount of literature that is available for BRI is quite limited, probably because after the BMI and the BRI, a few other indicators came up, which is basically the waist to height ratio, which has performed really, really well as compared to the BMI and better than the BRI also. So if we just look at the flow, so we had BMI, then we had BRI, then they came up with waist circumference, waist hip ratio, and now they talk about the waist height ratio. So if you look at all the indices that people have been exploring, then probably the BMI is something which is probably the most inadequate. BRI is somewhere in the middle, but then waist height ratio tends to perform even better than the BRI, and therefore probably somehow it's not taken up as like a routine measure that we would do in our clinics. So there are systematic reviews and meta-analysis around the BRI, and it does give us some indication of the visceral fat and its correlation with diseases, but doesn't perform as well as some of the better indicators. Having said that, ultimately all the ratios that we're talking are basically a substitute for actual measurement of visceral fat. And the indicators the methods which are the best are actually CT scans and MRIs to measure visceral fat, which unfortunately is something that we cannot do in routine practice, and so far is only available maybe for research work.
Right. So again, audience, if you have any questions, please feel free to send them over, and we'll be happy to take them as we discuss this session. So very rightly said. Do you think, Dr. Tejal, BRI is one of the reasons why it's not taken off is that it's slightly more complicated to calculate? Yeah.
That also is one of the reasons for sure.
Yeah. So I think one of the things which we have learned over a period of time is that things which are simple,
yes,
they get taken up much better, right? So BMI, though for all its flaws, somehow was a very simple measurement, and hence it took off much better. Dr. Tejal, something very interesting. What they found was that those people with a lower BRI also had a higher mortality. So anything mechanistically or any theories you can propose regarding this?
So I think body fat is extremely important for the production of such important molecules in the body, all our hormones, all the transporter channels. There are so many things where fat is really, really important. And I think it has all our immune cells, all of that. So adipose tissue is also very, very hormonally active. It's immune active. It produces, is responsible, especially for menopausal women, responsible for conversion of androgens into estrogen. So I think fat serves as a very, very important fuel for a lot of our body activities. It is protective, and it's a storage of fat for us. So I think that mortality increasing at very low BMIs is something that I think is quite, it's just intuitive. Even if you don't have evidence about it, I think it's something that which is just so natural, because fat is there in every part of our body, and it's an important molecule for our body to just function normally. So low fat, of course, will also increase mortality, and high fat also increases mortality. There's just one point I want to make. I've always had this question in my mind, and I don't have an answer for it, but I'm just throwing it up. So if you see, women tend to gain more weight than men, right? So if you look at a woman between 50 to 70, usually her fat content will be more than men. However, women live longer than men. So I also feel that there is some protective effect of fat as well. And if you look at the BMI studies, between 21 to 30 is actually not much mortality. The mortality only takes off after about 30, 32 kg per meter square. So a lot of times, though, if my BMI is 27, I am obese as the BMI category, but my risk of mortality is really not that high as compared to somebody with a BMI of maybe 22, 23. But once I cross 30, then that's the time that my mortality risk really takes off.
Right. So you're saying that, there's a possibly an inflection point where the things really change, right? And it probably maybe 30, maybe some other number, maybe determined by the genetics and maybe determined by the racial structure as well. But I think very interesting point. So women over a period of time, especially after a certain age, tend to gain more weight, yet they tend to still live longer, right? So I think probably, that's a very interesting question to probably think about in a long-term basis. I think, as we can understand, probably atherosclerosis, weight is one aspect of it, and there are many aspects of it, so it's a multifactorial thing. And I think, weight is one thing which we can control, but, we need to probably look at the bigger picture. Now, Dr. Tejal, what's very interesting is that this BRI has been there since the last decade. Probably, people forgot about it, but this study really brought it back into the equation. If you see, a lot of discussion on the social media and other things, this study, though it was published in JAMA, a good journal, brought BRI back into discussion,
Limelight.
in limelight, in the day-to-day discussion. I saw, when I was researching this article, I saw a lot of social media layperson chatter on this. So what's your view overall on this study? And does it really merit the importance it has got in social media or in general media?
So, my mentor, who was like the boss of evidence-based medicine, the first question he would always ask me is, whenever you read a really good study and you get very excited about it, first question you ask is this study applicable to my population, and is this applicable to my patient?
Right.
So unfortunately, though this is a great study, this is all US data. And if you look at the breakup of the numbers, we are clubbed as Asians, and these Asians include Koreans, like really different Asians, none of them which are a very cohesive group. So I think that though the study is great, I don't know if we can apply it to our population, first of all. So we would need data from our population. Some of the other things I looked at in the study is that they, so this is all based on the NHANES data, right? Which is across the US population. The response rate to the survey dropped from maybe 80, 90% in the 90s and early 2000s to as little as less than 50% by the time the 2010s came around. So the number of people responding to the surveys has reduced dramatically as well. So we need to take that into account when we interpret the data. One of the other things is that the mortality rate as such in the study, so though there were 59,000 people who were eligible for calculation of mortality, only 33,000 were considered because maybe the data was not available. So though it's a great study, it's brought BRI back into the forefront. Maybe there will be more, studies coming out around this, but we need to remember that this is mainly in Caucasian population. This is not really representative of Asian population. And the response rate to the survey dropped as the study progressed. So by 2018-19, the response was less than 50%. And the ethnicity also, most of them were non-Hispanic whites. So the generalizability or the applicability of the study to our population is something that we need to be careful about.
Right. So take it with a pinch of salt, I think, but at least it brings up area that, you need to probably explore this further. And it's an interesting, starting point for a very exciting discussion. Now, moving to something complicated to something simpler, right, is the waist to height ratio. Now, though this, the study and the corresponding, I've mainly kept the editorial rather than the original study, was published in 2023. So, it's an year, not exactly an year in review for 2024. But the point is that there's a lot of discussion this year about waist to height ratio. The simple reason is that, in the European Congress of Obesity, there's a lot of chatter on waist to height ratio, right? Especially, a couple of pharma companies investing big in the space of obesity medicines are bringing this back to limelight again. So waist to height ratio is again another measure of the central adiposity and cardiometabolic risk. Compared to the BRI, it's a very simple calculation to make, right? It's a very simple calculation. So all you have to do is you take your waist circumference and take your height and just, divide them, right? And it's a again, very simple to interpret, right? So waist to height ratio less than 0.5, generally considered to be healthy. And the waist to height ratio more than equal to 0.5 is considered to be higher risk. So it's a very simple, intuitive, easy to calculate thing, right? And all the person has to know is that the waist circumference, if it is more than half of your height, you're probably in trouble. So that's the whole idea of the entire thing, right? And the article we chose actually was an editorial which was based on a study published in the same journal. But having said that, like I said, why we brought this in this year is that because there's a lot of chatter at Eco 2024 about this. So the editorial, basically what they said was that waist to height ratio is a good anthropometric index, which often outperforms measures like BMI in predicting cardiovascular, cardiometabolic risk. And again, it also gives you this memorable line that keep your waist circumference under half of your height, which is very easy, accessible, intuitive, simple to understand. And again, it has been validated across the years in terms of various demographic groups. Again, it identifies people at risk and also has been correlated with all the metabolic complications, including cardiovascular disease and death. So that's the discussion. That's the point on waist to height ratio. And again, you can use the calculator which you put here, very simple to use again. And you can also use your pant size, which which we saw in one of the studies, which is unfortunately not perfect, right? But again, a lot of people cannot actually measure their own waist, or maybe don't know. So if you just go there, put in your pant size, you might well get not a perfect equation, but this is not meant to be perfect. So this does give you some interesting calculations also. So you can try this out. Again, the point about, so here, Dr. Tejal, you'll agree with me that BRI again is trying to replace BMI, and again waist to height ratio is again doing the same. But the difference is waist to height ratio is extremely simple to understand, extremely simple to calculate. BRI is more complicated. So again, why are we again, Dr. Tejal, so obsessed with this notion of central adiposity? Why does everybody want some way or the other to measure it? Why do we want to measure visceral fat? What makes visceral fat so interesting for endocrinologists?
So very honestly, I think when we were doing MD, we had no concept of all of this, right? Subcutaneous and visceral fat. It's only when you come to DM and you start talking about it and you understand there are different types of fat in the body. So if we talk about visceral fat, what we have to remember is that, as I already said before, not exactly, but visceral fat specifically, it's a very active fat, so it's seething. So it's very susceptible to hormone stimulation. So as soon as visceral fat undergoes lipolysis, it releases free fatty acids. And because it's so close to the liver and that entire abdomen, there's a direct release of the free fatty acids into the liver. So liver gets laden with fat, insulin resistance, developing fasting hyperglycemia. So one of the ways that the visceral fat is not so great is very susceptible to lipolysis, very sensitive to hormones, and can easily be broken down into free fatty acids and cause a lot of problem for the body. There's a lot of data which links visceral fat not only with cardiometabolic syndrome, but with cancers like breast, prostate, and colon. There's data which says that increase in visceral fat is associated with all-cause mortality, prolonged hospital stays, infections, and a whole host of things. So ischemic heart disease, hypertension. So one of the things is it's very susceptible to lipolysis. One of the other things about the visceral fat, again, is it's very active. So it produces a lot of hormones, leptin, adiponectin, resistin, interleukin-6, tumor necrosis factor alpha. So a lot of inflammatory markers are produced in the visceral fat. And this chronic inflammation is probably one of the key reasons which kind of helps atherosclerosis and propagates the atherosclerosis, and we end up having a lot of issues. Also because there's a lot of inflammation, a lot of the antioxidants are quenched, so a lot of oxidative stress, apoptosis. So one of the hypotheses for diabetes is that visceral fat in the pancreas actually causes localized apoptosis and destroys the beta cells. So visceral fat is active. It produces a lot of substances which are harmful. And that is the reason why we are behind it with hammer and tong and somehow want to do something about it.
Yeah. And you also talked about, in the earlier discussion that, there are other means of measuring visceral fat. For example, you could look at visceral fat using, actually a DEXA. You can use it, you can calculate using a CT scan, which is again,
Yeah,
you just have a single point of, it's like a single cut.
correct.
You can, you have this body impedance measures, right? Which exactly doesn't measure visceral fat, but, it measures the fat, and then, it can kind of, the software kind of correlates it with the different areas of the body. So there are different ways of measuring, though of course gold standard probably would be CT scan,
Yeah.
direct imaging. But there are other means of measuring it also, and like we already discussed, these waist to height ratios and other ratios are also interesting and important, right? Now, Dr. Tejal, direct correlation, this is a poll question as well. Uh, of the two, parameters that we saw today, which do you think, impresses you more? Which do you think probably will, again, maybe 10 years down the line, we'll still be talking about it, right? This has been around for a couple of decades already. A decade down the line, are we still going to talk about these parameters?
So do
Which
I have
of
to
these
make
two?
a choice between BRI and waist height ratio?
Yeah.
So waist
So,
height ratio. So there's
yeah.
a beautiful article I read which shows the progression of parameters to measure visceral fat. So at the bottom is BMI, then somewhere in the middle is BRI, waist circumference, waist hip ratio, and at the top of the pyramid is the waist height ratio. And also the body of literature around waist height ratio seems to be much more solid as compared to the BRI. So BRI was in vogue in 2013. Suddenly it's made a comeback, but probably maybe waist height ratio, and probably the reason why, most importantly, which you pointed out, is the simplicity.
Yeah. So I think things which are simple live the test of time, and I also completely agree with you, and also the audience agree with you. So about 40 people have participated, and they say that 84% agree that waist to height ratio is the one which probably impresses you more because it's a simple measure. And a very interesting question from Dr. Parag Agrawal.
Yeah.
So he says that why is it that obesity in female leads to virilization? A very interesting question. I think this is right in your alley. Okay. So why does obesity lead to virilization in females and feminization in men? Is it something to do with insulin resistance, aromatase activity, or could be both?
Yeah, so combination of everything. But what I would like to point out is that obesity is not directly related to virilization in women. So the pathophysiology of PCOS is slightly more complex than directly obesity equals to virilization. And a lot of other things also need to be, in play. A lot of genetic factors, environmental factors, the rapidity of the weight gain, the family history. So a lot of other factors are involved for obesity to translate into virilization, and all people who are obese are not do not have virilization. Also, I think insulin resistance has a major part to play. So there are IGF-1 receptors on the ovary, and when you have insulin resistance, IGF-1 receptors in the ovaries also get stimulated to produce testosterone, and which of course then leads to the whole PCOS complex. So in some people with obesity, yes, virilization can occur, and I would not use the word virilization. I would use the word hyperandrogenism, because virilization is a very strong word, which talk is mainly, an adrenal tumor, an ovarian tumor, which is producing pure testosterone, and the testosterone levels are maybe to the tune of 3 or 4, 5 nanogram per ml. That's when virilization comes into play. When we talk about hyperandrogenism with obesity, usually the values of the testosterone are like 60, 70 nanogram per DL. And men, of course, a whole different ball game. So you have lots of aromatase, lots of estrogen being produced, a lot of inflammatory markers. So one of the commonest reasons why we get hypogonadism in the clinic, and Om will agree with this, is because the low SHBG, reduction in the free testosterone, and men having a lot of that. So yeah, it's that is what it is. And the most difficult thing is to get people to lose weight. If only we had like the magic pill to get people to lose weight, then everything would be great.
Great. So
magic pill.
Yes, talking about magic pills, and it's more of magic injectables right now, but maybe pills as well. So I think, and let's talk about the next article, which is my favorite article of this year. I think this is really important, right? This is really important, and I'm really glad that somebody had the courage to do this study. I think it's more of that. So what they looked at, this is published in nothing less than New England Journal of Medicine, right? So it's liraglutide in pediatric obesity. So it's a very interesting groundbreaking research, as they would say. So what they did was they did an actual study, a randomized controlled trial for children between ages of 6 to 12. So it was a 56 weeks RCT, where they looked at obese children and they gave them liraglutide versus placebo, and they found that there was a significant minus 5.8% reduction of BMI in children receiving liraglutide compared to plus 1.6% increase in the placebo group, with nearly half of them. And remember, to the audience, most of these obesity trials, they look at 5% BMI reduction as generally the standard. So they looked at 5% BMI reduction, which was achieved in nearly half of the treatment group. Also, there were other cardiometabolic benefits like reduction in diastolic pressure, HbA1c reduction, and again, of course, it's a drug which can lead to GI side effects. So you had nausea and vomiting, which was the common side effect. But overall, what it tells us that there is a room for pharmacological intervention in 6 to 12-year-olds. So that was the interesting part. Just to tell you a couple of caveats to this, right? So a few things, again, people who are not used to pediatric obesity, because you have a lot of audience of ours who will be mainly dealing with adults. So if you talk about definition, and in this study, they looked at the age, sex adjusted BMI, and the criteria is something like this. So again, obesity is defined by age and sex adjusted BMI more than 95th centile as per the CDC growth chart. So that's again American bias there. They looked at mainly 6 to 12-year-olds. And again, they classified BMI based on class 1, class 2, class 3. So class 1 is those with BMI more than 95th to 128th centile. BMI class 2 was 120 to 140. And class 3 was more than 140, right, of the 95th centile. So that was what they looked at. Of course, they excluded people with type 1 diabetes and other causes of obesity and other genetic cause of obesity, secondary cause of obesity and all. And they also looked at the pubertal development. So they generally took 10 of 1 to 5. So they were pretty neutral about it in that group. So that was the idea. Mainly, they looked at liraglutide for this, right? And if you see the dosing regime, which was so this is what was very interesting. So they took this, for more than those children who were more than 45 kg, they started with 0.6 milligram for 1 week. And then they did a dose escalation of 0.6 every week, right, till 3 milligram or maximum tolerated dose of liraglutide. And for those less than 45 kg, started with a smaller dose of 0.3. And then again, the similar titration was done up till 3 or maximum tolerated dose. And overall, 89% of the participants successfully reached 3 milligram dose. Very interesting, because we don't even reach 3 milligram in adults, which is very, thing, right? So there's a gradual titration process which minimized the side effects, and most of the children tolerated the medication very well. Now, what is interesting is that they've actually ventured into pediatric group earlier. They had done a scale teens trial. This was a scale pediatric trial, scale children trial. It was done a similar trial in teenagers back in 2020, where they looked at liraglutide in adolescents with obesity, and that also led to FDA actually approving liraglutide as an agent for obesity in ages 12 and above, right? So that is how it had changed, right? So that was the scale teens trial. I'm not going to details of that. It was published way back 4 years back. But overall, that study also showed good efficacy in terms of, both the weight reduction as well as the other parameters also reducing, right? So, Dr. Tejal, your views on this article right off the bat.
Also, as a mother, it scares me to death, because I'm just being very honest, right? So when I read the article, great science, wow, we have something finally to treat young children with obesity. But we know the experience with liraglutide in adolescents. So I do use it for children who are between 12 to 18 and for adults. And I was just fascinated that 89% of the people were able to reach maximum, of the kids were able to reach a maximum dose of 3 milligram. That is something I'm not able to get my head around, right? Yeah. So maybe there's a difference, and children have better tolerability to GLP-1 analogs. We don't know. But definitely the number of kids who were able to reach 3 milligram was something that was difficult for me to get. I think one of the biggest challenges for using liraglutide in pediatric obesity would be the acceptability for parents. So as much as the science is great and we would love to offer it to young children, I think it'll be really hard and an uphill battle getting parents to kind of initiate liraglutide for their children. And also managing the nausea and vomiting would be challenging because young children, they eat at random times. They may not be able to express what they're thinking. So here I'm thinking both as an endocrinologist and as a mother, and it's a little bit scary for me. Having said that, the maximum takeoff of obesity does occur between 2 to 6 years of age. And therefore, if we could intervene early and we could kind of somehow break that progression of obesity, I think it would be great.
Yeah, so very interesting. So I think, and overall, Dr. Tejal, looking at how things are moving, what's your view on pediatric obesity in general? Is it, it's a problem, right? It's a problem for sure. Overall, in your practice, since we generally practice both adult and pediatric endocrinology, we do see patients of this age group. Again, keeping your mother's hat aside, your endocrinologist hat, how frequently do you see such patients, and do parents bring you children with just for obesity management at this age?
So I think they start coming in at about 9, 10, 11,
Right.
12. They usually don't come at 4, 5, 6. I think at that time, the child is so cute looking and is healthy. And, it's that
Right.
kind of perception. So here I would also, as an endocrinologist, talk about the cultural perception of weight. Is that I have parents who will hound me when their kids are normal weight all throughout till they're 10, 11, 12 years of age. And suddenly they start gaining weight. And suddenly now the same parents who were upset that their child is underweight are now upset that the child is overweight. Right. So this cultural perception, I think, plays a big role. But usually very young children don't come. I think 9, 10, 11, 12, that's the age where they start to come in. Most of the obesity that we see is non-syndromic, non-monogenic. I mean, it will be very rare that you'll see syndromic or monogenic obesity. I think the issue with pediatric obesity is it's not a problem of the child. It's a problem of the family. And a lot of things have happened which are completely out of the child's control. So if it was an SGA baby, the mother had gestational diabetes, what kind of medications the mother was taking, what is the family environment. There are so many other factors at play here that somehow it makes it more poignant, I think, for pediatric obesity, because it's very little that you can, blame the child for or, hold the child accountable for. Also, the other challenge for pediatric obesity is young children, they don't realize the repercussions or the implications of the weight in the long term. We have a hard time getting adults to understand the importance of obesity, getting a 10-year-old to understand the importance of obesity. And if everybody in the class is eating Maggie and pasta for their tiffin, and to convince that kid to take fruits and paneer, it's really, really hard. So I think there are so many levels to pediatric obesity. And liraglutide can be maybe one of the things in our armamentarium, but it has to be like a national level, cultural level, policy level intervention if we are to kind of, manage pediatric obesity.
Yeah. So very interesting point. And, great concepts and, $2 million questions. Okay. So that's $2 million. $1 million question one. Would you, and I'll ask you to answer both of them together. Would you use, given an option, parents are open to it, would you use liraglutide in your pediatric patients with obesity? B, and this is what your parents would ask, and I'm sure it's the next question which will come. How long would you give it?
So I just had, so the first question is, yes, I would use it. Yeah, because until we have the answer for how long, then yes, at least I would use it for as long as I can. So I just had a seminar this Sunday and it was all about the body weight set point. So as of now, there is nothing which moves the body weight set point, right? All the drugs, all the surgery, whatever we have for management of obesity does not have an answer for the body weight set point. So for all medical options that we have till date, including maybe tirzepatide, the weight stays off as long as you take the medicine. The weight comes back, all of it, once you stop the medication, because we haven't done anything to address the root underlying cause of the obesity. So yes, it doesn't mean that because I don't have a permanent answer, I don't offer the benefit of the medication to my patients. But yeah, just wait and hope that something comes up in the next few decades, at least in my lifetime, which would help us to manage that body weight set point and help people to stay, keep the weight off even after stopping the medications.
Right. So very interesting. So I think, all good points. And this is the same poll question we asked to our audience as well. And interestingly, 70% are open to possibly using liraglutide in their practice. So at least, it gives you an option that there is something you can offer. And, like I said, no less than New England Journal of Medicine, which gives it a very strong authenticity to really prescribe the, medication in India, right? So that's great. A couple of nutrition reviews and two very, again, a lot of social media chatter around this, especially the second one. So first was, came a few months earlier, was about tomatoes as a natural ally to blood pressure. Just to put it very simple, they said that, consuming a lot of tomatoes, this is called, they have a name for it. It's called a PREDIMED trial. And they looked at, giving tomatoes, and what they found was that there was a reduction of blood pressure with the tomatoes. But the one which is now currently in vogue, and this is still, the chatter goes on as we speak. This is a study published again in BMJ, no less, which looked at dark chocolate in terms of diabetes defense. Very interestingly, they found that people who consume dark chocolates are actually protected specifically from type 2 diabetes, whereas those who have milk chocolates have a slightly increased risk, right? So very interesting use case for dark chocolate. Now, moving from pediatric obesity to dark chocolate is a very interesting dark, change. Both the articles, but let's start with personal. Do you like tomatoes or dark chocolate anyways? So
yeah, I like both very much.
Yeah, great. So then we are on good footing. So first of all, do nutrition studies like this actually make sense? Does it, because it gets a lot of media chatter, right? And it just gets a lot of attention. It seeps into people's minds sometimes, on the wrong side as well. Does it really does it change anything, to be honest?
So just let me put this in perspective. Somehow when they get headlines, the connotation is that if only I ate more than 110 grams of tomato per day, I will never get high blood pressure.
Right.
So, right, that's the answer people look. So tell me that one thing I need to do and I won't get diabetes, I won't get hypertension, or I won't become overweight. So none of these studies mean that. So just because I consume more than 5 servings of dark chocolate per week, but if I'm also having a milkshake every day, then it doesn't mean that I'm going to be protected against type 2 diabetes. So the point I'm trying to make is that none of these are standalones. And if you look very carefully at the studies, I don't know if you've read them carefully, but I went into the details of the dark chocolate one as well. And what they found is that those people who ate dark chocolate were also more likely to have red wine, more likely to have blueberries, more likely to exercise, and more likely to eat food which had low calories and less saturated fat. So the people who consumed the tomatoes and the dark chocolate were also people who were innately health conscious. And it's a lot of other factors which come into play. And then there is some benefit of maybe the dark chocolate and the little amount of flavanol which may be there. So it is not the panacea for all ills. Popping one piece of chocolate or eating 2 tomatoes a day is not going to prevent diabetes and metabolic syndrome. However, they're indicative of people who are health conscious. And this habit, along with maybe a lot of other good habits, can probably translate into maybe better outcomes.
Very interesting. So I think it's a great point. Again, I think we need to again take it maybe with a pinch of salt or pinch of with a piece of dark chocolate. That all these studies have these caveats involved, and I mean it's literally impossible to do a randomized controlled trial in a very perfect way. Again, I mean, even in terms of any fruits or vegetables, we also need to look at, there are species of that, subspecies of those as well, right? So some of them may have certain benefits, some may not. So I think it's a interesting, yeah, I think you raised your hand. So
yeah, there is actually a randomized controlled trial. They looked at dark chocolate to prevent type 2 diabetes, and it was not successful. So I'm just verifying your point that though this observational data and cohort data and all may look very attractive, there was actually a Cosmos study where they used dark chocolate as an intervention. And though it had some effect on cardiovascular risk, it had no effect on type 2 diabetes.
Interesting, right? So I think end of the day, in the pecking order, I think, an RCT really thinks, but at least, it's an interesting area to really look at, in this. So moving on, and let's move to from, eat, sleep, repeat, so it's now sleep. So we already ate, and now, it's about sleep. And, we all know about sleep disturbances in diabetes. You have OSA, obstructive sleep apnea, you have diabetic autonomic neuropathy impacting sleep. You have, some of them have nocturia, polyuria, restless leg syndromes are common. Again, hypoglycemia can lead to sleep disturbances. So diabetic patients tend to have a lot of sleep related issues, right? And one of them, I think, predominantly, which is often goes under the radar, is the obstructive sleep apnea, right? So OSA, by definition, is a cessation of airflow or apneas more than at least 5 episodes. So apnea is when more than 10 seconds of cessation. Hypopnea when you have 50% reduction of airflow for more than 10 seconds. So and when you clinically assess OSA, people complain of daytime fatigue. And I think you will see a lot of these patients, come and tell you about fatigue. I feel tired, snoring, and when you witness apnea during sleep, these is a classic triad of the OSA. And then you have all these screening questionnaires, the Epworth sleepiness score, the Berlin questionnaire, the stop bang, which is easy to perform screening test in your outpatient practice. So, and of course, you have gold standards. You have the, polysomnography and the home sleep apnea testing, which is becoming very popular now. And as a lot of you would know, Apple Watch now has the latest update will come with OSA detection as well. So that's already there. So if you are using some of the recent Apple Watches, it's just a software update which will come with the sleep apnea. And they said they've validated that with the gold standard, which is interesting, right? So gold standard, of course, remains the standard sleep study. And if you have people who have snoring, witness apnea, gasping during sleep, and with daytime somnolence, I think that's where you really look at OSA, right? So I'll not go into too much detail, but talking about OSA and diabetes, 40% OSA, patients develop diabetes. And then again, 23% of patients with diabetes have OSA. So both have, it's a bidirectional link there. And sleep disorder breathing in a more broader sense is much more common in diabetic patients, right? Now, there are various ways of managing, but I think there are two drugs which have now come as a sort of ray of hope, because management of OS is very complicated. Apart from the lifestyle measures and other things, I think the CPAP and the auto CPAP are very complicated. Patients don't find it very comfortable. Some do, not all. And then, of course, surgeries are again even more controversial and complicated as far as OSA is concerned. So there are two studies, and I take both of them, published in 2024. One is SGLT2. This was published in a relatively simple, journal, but I think it has a lot of importance, right? So you have SGLT2 inhibitors and sleep apnea, and this is a very interesting study which looked at, the importance of SGLT2 inhibitors in patients with OSA and diabetes, right? And what they found was that there was patients on SGLT2 had a significant reduction in the AHI index, which went from 28 to 15. So there was a 60% reduction independent of weight loss, which makes it very interesting, right? So that's the thing. And again, there were other sleep parameters also improved. So again, SGLT2, and they looked at a slightly older population. They specifically said that an elderly population may have a good, potential use case in type 2 diabetes and sleep apnea. So that makes, SGLT2 very interesting use case here. And similarly, this is again published in New England Journal of Medicine, which looked at tirzepatide for sleep apnea and obesity. And again, I think a very interesting study here as well. They found, they did two rigorous phase 3 trials, 52 weeks, spanning 52 weeks. They looked at giving tirzepatide for obesity, for sleep apnea and obesity. And this is again beyond diabetes management. So again, looked at it and they found significant reduction, improvement in as far as the OSA parameters are concerned, both objective and subjective parameters as well. So this was published in the NEJM, right? Now, broadly, Dr. Tejal, OSA and obesity, diabetes, and OSA, I would say OSA for endocrinologists, how important it is in your practice?
So the specific patient subgroups, of course, somebody, if tells us clear-cut symptoms, of course, we'll investigate for OSA. But there are some patients, who have very difficult to control diabetes, very difficult to manage hypertension, they're gaining weight without, really, there is no change in their diet, or they're trying to lose weight and not able to lose weight. So those are the kind of people where the metabolic outcomes are not going as per what I would like them to, depending, as compared to the effort that you're investing in lifestyle modifications, then those are the patients who I would suspect that would have OSA, mild subtle symptoms of heart failure, BP not coming down, diabetes not coming down. Those are the people who I would want to specifically screen for OSA.
Great. And do you have any go-to process which you follow for OSA screening? So do you directly send them, or do you do these questionnaires? or do you send them to a pulmonologist directly for a sleep study, or do you do the sleep study yourself, or do you use some of the home kits which are now available? Some of them are available on Amazon as well, or maybe an Apple Watch or a third-party software which kind of helps. So what's your let's say a patient strongly feels that patient needs to be screened for OSA. What's your next step?
So the stop bank is really easy to do. So I have this habit that whenever I find a questionnaire or a risk calculator or something like that, which is very handy, I just bookmark it on my software in the clinic. So if there is somebody who I feel like may fit into this, you quickly do the stop bank. It takes not more than 30 seconds.
Right.
And the gold standard is polysomnography. So you could use all of these other things, but I think polysomnography is the gold standard. And I usually refer to a chest physician and let them do like a detailed assessment. But you know that what is going to happen is most of the time when OSA is diagnosed also by the chest physician, the patient comes back to you because what is recommended is weight loss before a CPAP, because the acceptability of CPAP is really low. So most of the time the patients then do come back to us, but now they have like a proper diagnosis. And I think that makes it so much easier for us to convince them to maybe like use an SGLT2 inhibitor, use a GLP-1 analog or a GLP-1 when it is available. I think having like a proper diagnosis and a confirmed diagnosis, I think makes people also more amenable to treatment.
Right. So I think it's a great point, and specifically on SGLT2. So do you find, because you still don't have tirzepatide in India, SGLT2 inhibitor, so looking at this study, does that become a compelling indication of prescribing SGLT2 especially if you have your patient where you're suspecting or confirmed to have an OSA?
Okay, so the kind of patients we see home, which is type 2 diabetes, I think we have to find an indication not to prescribe an SGLT2 inhibitor. So yeah, I think that's a no-brainer that all of us would like to use SGLT2 inhibitors in these patients. Cheap, easy to get. It's an oral formulation, so I think that's a no-brainer.
Right. Okay, so we put out this poll question, and audience, you could please participate. So what's your generally go-to method? Do you screen patients, obese patients with diabetes for OSA, or do you do it in selected patients, or do you generally consider, right? In fact, Dr. Tejal, there is now a school of thought that, like you said, there's subtle symptoms of OSA, and now you have potential drugs to be offered. Why not screen a larger population instead of just selectively screening? So I think, maybe at least, if not anything, maybe offer the stop bank questionnaire to more people, that could be very interesting. So I'll leave this poll, running for a few minutes, and we'll come back to this in a few minutes. But while we discuss some more use cases for GLP-1 RA. So I think this has been, without a doubt, entire year in review of endocrinology, if you say if it has to be boiled down to maybe one slide or one thing, it has to be the creative use cases for GLP-1 RA. It has been 2024 has been the year for GLP-1 RA. It has literally, taken the world by storm in a lot of ways. Again, there were this year alone, and if you see New England Journal of Medicine, if you just screen that, filter out, endocrinology and the research papers published, most of them, I think 80% are to do with GLP-1 RA, right? So use cases are above and beyond obesity and diabetes. Tirzepatide looked at MASH treatment, right? And they actually found MASH resolution without worsening fibrosis. So this is something, it's an interesting study. And we have put the entire study there in our module, so you can go through that. But there was actually improvement in fibrosis, which is, I think, the essential interesting area. Whereas they looked at semaglutide also in NASH cirrhosis. This was actually in cirrhosis patients, and they found that it did not reverse advanced cirrhosis, but then again, the metabolic benefits continued to be there in cirrhotic patients also. And then moving on to semaglutide, and very interesting use case is in knee joint osteoarthritis, again published in no less than New England Journal of Medicine, where they found that there was actually significant improvement as far as the overall outcome of the patient with knee joint osteoarthritis was concerned. So I think these three studies very interestingly look at GLP-1 RA in a broader context. Now, again, if you this is mainly from NEJM, but if you look at the other journals as well, you'll find even more larger use cases for this. There is a STRIDE study which Novo Nordisk is going to, the top line results have been announced, where they looked at using semaglutide for peripheral arterial disease, where they found significant improvement in the walking distance, which is very interesting. There are ongoing studies for use in stroke. there are specific use cases in, and very interestingly, de-addiction medicine, right? So as a, in alcohol de-addiction, there are ongoing studies there as well. So I think what it tells us is that GLP-1 RA may have use beyond obesity and diabetes management, which makes it maybe a pan-metabolic drug. Let's start off the bat, your views on these articles and, in general about future of, these agents in uses beyond diabetes and obesity.
So I think the common soil is the obesity, right? And anything which addresses that common soil, it's obvious that all of the fallouts of that obesity, all of that will naturally be addressed if you address the obesity, right? So knee osteoarthritis, physical stress on the knee is a large part. Obesity-induced inflammation can worsen knee osteoarthritis, right? So I think it's the obesity, which is the common soil. And then we're just kind of picking up one, each and every fallout of that obesity and trying to say, okay, this drug is the best. But having said that, yeah, obesity is hard to manage and lifestyle interventions are difficult to sustain. So yeah, I'm all for it. And I already do use semaglutide for people with knee osteoarthritis. So my husband's an orthopedic surgeon. And every time somebody goes with knee osteoarthritis to an orthopedic surgeon, they're all told, lose weight and come back. Right. But then we are supposed to tell them how to lose that weight. So I do use semaglutide, especially preoperatively in many patients, who are very severe pain or who are not ready for knee replacement. Then I do use semaglutide. And yeah, I mean, if we are having expanding indications, I think nothing wrong. The more we offer our patients, the better.
Yeah, absolutely. And, I think one area I'm 100% sure 2024 was about GLP-1 RA. 2025 is going to be year of MSLD. There's going to be already there are some early waves of this. GLP-1 RA itself is now increasingly being used in this condition, but there are newer drugs as well. You already had resmetirom this year, last year rather, which was there for this indication. So currently now, of course, we in our country are limited by the drugs which are available to us, but MSLD, your general views on this, this disease, this area, this syndrome, and how do you, as of now, approach these patients in your practice?
So I think one of the earliest indications we had of the approaching epidemic is when I was doing my residency, and I would notice elevated liver enzymes in many people with type 2 diabetes who otherwise did not have any liver disease. And at that time, they were non-alcoholic. So at that time, I never made the connection. But now, of course, this area is exploding. So the simple thing that I do in my clinic, and I'm a big fan of calculators. So I simply use the FIB4 score. It's bookmarked again, in my clinic laptop. And if it's less than 1.3, the FIB score, there's a free online calculator. You can simply use it. The score is less than 1.3, then, I'm not really worried and I don't take it further. If it's between 1.3 to 2.6, most of the time, intense lifestyle modification, offering methods to lose weight, which include GLP-1 analogs and SGLT2 inhibitors, is the way I go. If the score is on the higher side, so I use it very simply, 1.3 and 2.6, and it's a multiple, so it's easy to remember. So if they're closer to 2.6, then I would also maybe subject the person to a fibroscan, and depending upon what I find in the fibroscan, I would consider referral. So if the degree of fibrosis, so if the liver stiffness is more than say 8 kilopascals, then I would not interfere with this patient because it's an advanced stage. There's nothing that I can help the patient with, and I would refer them to a gastroenterologist. But if they're between 1.3 to 2.6, weight is still, it's mainly liver fat rather than the fibrosis, then weight loss intervention is what I would do.
Yeah. And I think, I'll tell you something very interesting. So at a, interesting lunchtime discussion with our gastroenterologist and our nephrologist were there. And, what we kind of found was that chronic kidney disease, because it's just a creatinine value, which, a lot of people understand. And, EGFR, of course, people have started calculating a lot and, they are able to recognize it. On the other hand, a chronic liver disease often goes under the radar, right? Most people's perception of CLD is that, the bilirubins will be high and SGPTs will be high. But if you see the FIB4 score and if you see the, thing, it's often under the radar. You'll have the platelet counts, which are going low, you have the PT-INRs, which are going high, and, albumins, which is low. So I think it's more subtle, more nuanced. And I think, maybe if not anything, at least we'll be diagnosing CLDs, chronic liver diseases, much earlier, which I think makes it much better in terms of offering them a treatment, because right now, one of the grounds of a gastro and hepatologist is that patients come too late to us. The first time they said, most of the time, the patients with CLD we are diagnosed when they come with a massive hematemesis, right? And that's the first time, they come to know that there is a chronic liver disease, or come with a ascites, with SBP. So that's a problem. A lot of time they get diagnosed much later. I think this is where endocrinologists can play a key role, that maybe pick them up at an early stage. And moving to knee joint osteoarthritis, and it's very interesting. There's actually a question from the audience as well, Dr. Tejal. Do you think this benefit is beyond just the weight loss which is offered by semaglutide?
Yeah, so that's a very interesting question, and I was looking at, the article and everything. So yes, there seems to be some benefit, because it also has some benefit on the pain score and the increase in the physical function of the person when they use semaglutide or liraglutide for these patients. So the three main outcomes they had in the study was, one, of course, the fact that they lost weight, but the pain was reduced and their physical function improved, and the stiffness. So I think some kind of anti-inflammatory maybe effect with reducing the adiposity, because one of the other things they noticed in the trial is that people who were on the semaglutide arm actually required less NSAIDs as compared to the placebo arm. So I think some anti-inflammatory effect because of the reduction in the fat mass definitely seems to be at play. And we can't explain the outcomes only by the weight loss alone.
Yeah, very interesting. So I think, that makes it, in fact, one of the interesting areas where GLP is now looked at, we see that it actually reduces chronic inflammation, right? So if you see, again, in terms of obesity, atherosclerosis, even MSLD, you're not only reducing the fat and the actual fat quantity, but you're also reducing the associated inflammation with that, right? Because they're now, they started looking at the corollary markers of chronic inflammation also, and they found that there is reduction there as well. So I think, you're right. There could be a potential play of reduction of the chronic inflammation, which kind of contributes to the improvement in the arthritis, knee joint, especially knee joint osteoarthritis, because there is a link there with chronic inflammation there as well. So I think maybe there is an interesting link which needs to be explored further. It probably may not be just because of the weight, which makes it very interesting, right? So we are running some polls. Again, these polls will be, because we're running short of time, so I'm just rushing through these polls. You can check it out on our, technochronology.com. The polls will be there. And, there's a little discussion area also beneath that, so you can post your views there as well. So I think we end here, right on time. And thank you, Dr. Tejal. Thank you so much. I think, it's always a pleasure interacting with you. You are the master of communication anyways, but, it's always fun to interact with you. And just a couple of quick questions. I'll just, quickly coming just to finish it off. Dr. Arun Kedia has asked that, do we have some sort of receptors in joints, like in the brain, just like we have for other, organs, right? So is it something to do with some, just to kind of, is it some central action which we are dealing with in terms of pain reduction as far as GLP RA is concerned?
I don't think so, but I'm sure that if we look it up, because, macrophages have GLP-1 receptor agonists. A lot of our immune cells also have GLP-1 receptor agonists. So I'm sure chondrocytes also would have GLP-1 receptor agonists. I don't think it's a central mechanism. I think probably a more local one.
Yeah. Okay. Great. So once again, thank you so much, Dr. Tejal. Thank you for thank you for being a part of this, session. And again, to the audience, so we are going to have the part 3 with Dr. Silima in the the next week, where we're going to discuss about the breakthrough research in diabetes. So stay tuned for that next week. So please register. We'll share the links soon with that. So Dr. Tejal, thank you, and have a lovely evening. And thank you to the audience for joining us for this. And we'll see you next week. Thank you.
Thank you so much, Om. And it's an amazing idea, and I hope you do many, many